Again, because this is the watershed area, the G junction, and the collaterals are present on either side, isn't it, at the level of G junction. So you can have varices in the esophagus which are extending into the stomach also. So depending upon whether those esophageal varices are extending along the, once you enter into the stomach, what will you have? Lesser curvature, greater curvature, isn't it? We saw that yesterday. If they are extending along the lesser curvature, they are known as gastroesophageal varices. They are combined now. They are not esophageal. Now they are gastroesophageal varices type 1. If they are extending along the greater curvature, this is GOV2. GOV1, GOV2. Okay? Or you may have isolated gastric varices also. There are various causes, etiologies. If there are no esophageal varices, but you find varices in the fundus proximal body, that means isolated gastric varices, IgV1. Again, depending upon the site, if they are located in the distal stomach, they are called IgV2. Okay? So these are the kind of gastric varices which you can have. Gastroesophageal or isolated varices. This classification gives you a lot of information about it. So Dr. Sareen is actually one of a very renowned gastroenterologists from India. So the Indians, because we are all surgeons, we are normally not aware. He is the ex-HOD of AIMS Gastroenterology Department here in Delhi, still running the ILPS Center in Delhi, heading that department. And way back in the late, you see this, he gave this classification. And this is a world accepted classification for this. This is how we classify gastric varices. So see this. Now this is GOV1 along the greater curvature, fundus GOV2. Or you can have isolated IgV1, IgV2. Look at the incidence of the diseases and the risk of bleed. The risk of bleed is highest in IgV1. But the cause here is not portal hypertension. The cause here is usually splenic vein thrombosis. It leads to isolated varices. So this is also known as left-sided portal hypertension sometimes. Okay? So risk of bleed is almost 90%. And this is followed by this. The risk of bleed 60% in GOV2, then GOV1. So site is important as far as the risk of bleed is concerned. The site is important. Okay? And depending upon the etiology, the treatment will also vary. So these varices, GOV1, you will treat like esophageal varices. That means banding sclerotherapy. GOV2 also you do some sort of sclerotherapy, but it is not the same thing. It is a different kind of sclerotherapy agent. We inject or commonly used what is known as cyanoacrylate. Nowadays we are also coiling and all those things are being done. So this is apply this. Whenever you see esophageal varices, what kind of varices you are looking at? Grade 1, 2, 3 or 2. When you are looking at gastric varices, what kind of gastric varices? GOV1, 2, IgV1.
We could have a combination of IgV2 and a GOV1, right?
Of IgV2 and
A GOV1.
GOV1. Less likely.
That's like
Less likely. There are, as I told you, the etiology can be different sometimes. Okay, but yes, it is rare to see both of these. Either you will have this, but you may even have varices developing within the, because it's just portal hypertension. You may have these kind of varices developing in duodenum also, within CVD also. But obviously rare advanced things, we are not talking about all those. So right now, this kind of scenario, you must have to identify. So the third thing which I pointed out was that area of mucosal erythema. I told you must make a note of the color of the mucosa over the varix, not on either side. They are all varices, they are all dilated venous channels, they are all covered by mucosa. If the mucosa over the varix shows any sign of any area of redness, this is considered as a risk factor or a stigmata, high risk stigmata, that this varix is now going to bleed, or it has recently bled and it will bleed again. High risk stigmata for variceal bleed. It is important for us to pick up before it bleeds. So this indicates a high risk of. And this red color of the mucosa can have various appearances. It could be like a stroke of paint with a brush, or it could be in the form of cherry red spots, or some hemocystic spots, or diffuse erythema. But basically, there's all redness over varix. Even if you don't remember 1, 2, 3, and 4, what were the various names or appearances, broadly speaking, any area of mucosal redness on the varix is collectively, we call it the red sign. So this is the third thing which you have to mention. Okay. First, you have to mention the type of varix, esophageal, gastric. Then you have to grade those varix. Third, you have to mention whether you see a red sign. If you say that there is a red sign is seen, that means now this varix is a highly likely to bleed. Isn't it? Now the onus is on you. Now supposing you send this patient home and the patient bleeds, the responsibility is yours, isn't it? Responsibility is yours. So either now you discuss with the patient and do the therapeutic treatment here in the form of banding, sclerotherapy, whatever you want to do. But if there is no consent or for whatever reason, then you must mention in your report, advise this treatment. Then your job is complete. So remember that. Okay? So you must mention about these signs and then either do therapy or advise. Because the responsibility lies on you. So this is how varices will bleed when they bleed. Although these are all dilated, tortuous venous channels, but they bleed profusely because of portal hypertension. You see that? It's pouring blood, pouring out blood like a quantity. It's not pulsatile, but it's pouring out blood. And this is how a banded varix will look like, just to introduce you to this procedure. So what you are basically doing is, you are putting this black band on the varix. Exactly like you would be doing banding for your hemorrhoids. Exactly the same thing. Hemorrhoids are also, tortuous, dilated. Exactly the same way. It's exactly the same kind of a band. The technique we will learn how to do, but this is how it will look like. So how does this work? We have obliterated this channel now. Okay? The blood supply is cut off, the flow is cut off. Ultimately, it is going to get all dried out, shriveled off, and shed off from here, leaving behind a raw area. It will all become fibrous now. So you have occluded this channel.
And what time does it fall?
It takes around 7 to 10 days. It will fall.
7 to 10 days.
Yes. Exactly as with your hemorrhoids also. So slowly and slowly, it is going to shed off from here, leaving behind a raw area. If you do endoscopy after 7 to 10 days, you will see a raw area there. You will not see a varix. Everything is fibrous. But that ulcer, that raw area is like an ulcer, it will also heal. It is going to get covered by normal mucosa. So if you see that ulcer, you call it a post-EVL ulcer. EVL stands for endoscopic variceal ligation. Or what is a technical name for banding. Endoscopic variceal ligation. Okay, so you will see a post-EVL ulcer also happening sometimes. So let's go to the next slide. So when you are practicing as endoscopist, you are going to get patients of this acute variceal bleed and all. So it's not just banding. Banding is just one aspect of managing these patients. In fact, you have to do a lot of other things. It's not that the patient of variceal bleed has come and you directly take him for scope. That's wrong. You should first do all these things. Start the patient on these vasoactive drugs, optimize your patient, correct the coagulopathy, start antibiotic prophylaxis, and then endoscopy. So to manage a patient as a whole, you must do all this before you even do endoscopy. Okay, that's important for us to understand. Now, if you say that a bleeding patient comes and I am waiting for the endoscopy, how is it justified? It is justified because every person is going to face these scenarios. And This is what the guidelines are telling you. You should not rush in to do endoscopy for acute bleed also. Okay? What is the correct time? Endoscopy should be done within 12 hours of admission. Within 12 hours of admission. Once the patient is hemodynamically stable. That means you have to do all those things first. You should start your patient on vasoactive drugs like terlipressin or octreotide, whichever is available to you. And they are wonderful drugs. You bring down the portal pressure and the bleeding usually stops within 3 to 4 hours. Okay? Actively bleeder patients, even if you try to scope, you will not see anything. It will be just blood. You keep on sucking on it, it will worsen the bleed. Okay? So start the patient. Obviously, low hemoglobin, give a transfusion. Most of these patients, portal hypertension, cirrhotic, whatever, will have coagulopathy. You cannot do sclerotherapy or put a band if the patient already has deranged coagulation. Do not stop. It will worsen. So usually you require 3 to 4 hours to do all those things. And you have been given a window of 12 hours from admission. These are societal guidelines. Okay? So proceed in a proper stepwise manner. Optimize your patient. Once your patient is hemodynamically stable, then do the endoscopy. And then, the cirrhosis is basically a progressive disease. So as long as there is underlying portal hypertension, newer varices will keep on forming. So variceal banding is not a one-time job. You are simply, doing a symptomatic treatment here. Isn't it? Varices, they bleed, okay, we'll band them. We're not treating the underlying cause, which is portal hypertension. So along with this, the patient would be on medical management and all your non-selective beta blockers, propranolol, to bring down the portal pressure. That part is there. But sometimes, in spite of all these disease, management, the disease progresses. Cirrhosis is actually irreversible, and some of the cases don't respond to medical management. So patient will keep on coming back with repeated varices and repeated bleeds. So you may, require to put the band 2 or 3 times until all the varices are, all the collateral channels are now obliterated. But supposing patient bleeds profusely, is not responding to medical management, then as an endoscopist, as a treating person, you must know the other alternatives which are available to you. You may not be doing them, but you have to advise the patient now to go for a TIPS procedure. Okay? Transjugular intrahepatic photosystemic shunt. This is a procedure which is done by your interventional radiologists. They put some coils, which are they are actually these stents, which they put through the catheters, and it immediately brings down the pressure. It has its own limitations, complications, and all that, but it will buy you time, because the definitive treatment is going to be a liver transplant. Okay? That will give you time to optimize it. So this is one option which you should be aware of. And then I told you there are 2 options for these esophageal varices. Either you can band them or you can do sclerotherapy. Where to use which method? Between, for grade 2, grade 3 varices, you should do banding. Grade 1 varices are so small that you cannot put a band on it. So for grade 1 varices or small residual varices, after banding also, you must do sclerotherapy. But for grade 2, grade 3, when you have both the choices of sclerotherapy or banding, then you must do banding. Banding is better than sclerotherapy. Okay? Some other options which you should be aware of to control these bleeds. So I'm discussing this topic a little bit in more detail because you have to manage the patient. This Minnesota tube is a modified version of your Shanks-Staples tube. So this is another option which you can use. It has 2 balloons and 2 lavage chambers. So First you put this tube inside and inflate the gastric balloon and now pull it up. The idea is to provide pressure, tamponade at the G junction. This itself, is sufficient to control the bleed here. And you provide this traction, pressure by applying a traction from outside. So this tube is ideally put with the patient, in the intubated patient, endotracheal tube, actively bleeding patients here. You have to protect the airway there. And then you can, after some time, you can do a gastric lavage and see whether it is clear or not. Same time, you can also do esophageal lavage here. There is another separate channel for that. If you find that the gastric lavage is clear, you have esophageal bleed, then you can go ahead and inflate the esophageal balloon also. So this is how you use this. Again, temporary method, and you cannot keep it long. This is called pressure necrosis. So temporarily, and then after an hour or two, you have to deflate this balloon and relieve the pressure.
An hour or two?
Yes. The longer you keep, the longer the risk of ischemia is there. So after an hour or two, just let it deflate it, then again you can inflate. This is just to buy time actually. Another way is this endoscopic placement of this special kind of a stent. These are not your routine endoscopic stents, although this is also a self-expanding metallic stent. This one has been designed specially for control of acute variceal bleed, which is not responding to the other banding and sclerotherapies. And this is a stent which you can place endoscopically. It is more bulkier, bigger stent than a routine SEMS. They are called the Dennis Ella stents. You can put them endoscopically, and again, it's a big, huge stent, and once it goes there and you expand, it expands like this, again works by tamponade. It compresses all those varices and stops the bleeding. So various options are available. This is all endoscopy aspect of varices. Now once you have bandaged the patient, bleeding has stopped, second day patient is fine, no active bleed, you send the patient home, advising to come for a follow-up because you expect further varices to develop. So you must advise the patient a follow-up endoscopy after 4 to 6 weeks. And you have banded all the bigger ones. You don't expect the patient to bleed, obviously. You are sending the patient on medical management after EPM. But same patient comes back to you with active bleed again within 7 to 10 days. You don't expect this. Sorry? Migration of what?
Stent.
No, I'm not talking about the stent scenario. I'm saying that you have banded the varices. Because the stent will stay there for, you can leave the stent there for 10 to 12 days and then remove it. This is again because of tamponade also. So 10 to 12 days by the time you decide, okay, what do you want to do next? Whether you want to do a TIPS or a transplant or not. I am asking about a scenario, this is a different scenario, when you have banded the patient and sent the patient home with medical management, no active bleeding. And all the bleeding varices have also been either sclerosed or injected or banded. So you call this patient after 4 to 6 weeks to look for newer varices, or if the residual varices are becoming bigger and they need to be banded. These patients usually do well. Once in a while you will have a patient who comes back sooner than you expected. Within 7 to 10 days of varices, again the patient is bleeding. Now what is the cause? We have already banded the bigger ones. Now the cause is, 3 things can be. The disease is progressive, the newer collaterals have developed into bigger varices. Or the residual varices, grade 1, which were left, they have now rapidly become bigger in size. Or the third option is, now that post-EVL ulcer is bleeding. Do you remember? That raw area which is left behind, and because before it heals by mucosa, now that post-EVL ulcer can also. But now remember that ulcer, that bleed is actually a ulcer bleed. It is not a variceal bleed now. So you treat it like a peptic ulcer bleed. Sclerotherapy, energy sources, bipolar, monopolar, clipping and all that. You don't put a band over it. You cannot put a band over an ulcer. If it is recurrent varices, then you do the same. You put a band. Okay? So you must differentiate between the source of bleed in this post-EVL scenario. Okay? This is what I was talking about. Third common disease which you will see now during your endoscopy practice is a hiatus hernia. So now we understand this anatomy. I had already discussed that we are looking at two junctions here. Again, quickly. So these are the gastric folds and they are ending here. You see, there are no gastric folds here. They all end at this level. So this is the level of anatomical GE junction. And you also see the Z line, which is the mucosal GE junction. And they were both present at the same line. That means what? That means the Z line is present at the upper end of the gastric folds. So the two junctions are at the same level, how it is supposed to be. This is normal anatomy. So what happens in hiatus hernia? Hiatus hernia is basically the herniation through the esophageal hiatus. So the intra-abdominal esophagus, GE junction, everything migrates up into the mediastinum through the hiatus. This is hiatus hernia. Basically of two kinds. One is the sliding type, is the, see this. Sliding hiatus hernia is the commonest variant. So this is your diaphragm. This is your hiatus. Through this hiatus, you see that the contents are now sliding up. The GE junction is here along with proximal part of the stomach and draining part has been pulled up. This is the commonest type 1 sliding hernia. Or rarely you can have this where the GE junction is in normal position but proximal part of the stomach or the fundus has now migrated alongside the esophagus, paraesophageal hernia. Or you may have a third common variant combined. Both sliding as well as paraesophageal component is present. How to diagnose a hiatus hernia on endoscopy? So we now know the junction. We now know where the G junction is. So when a hernia occurs, this junction will also move up. Isn't it? It will migrate up, it will herniate up. But how do you know that it has migrated up? You measure the distance. So right now here a 2 centimeter distance is marked here. But we know that this is the G junction. What is on the other side? This is the level of the diaphragmatic impinge. So the hiatus has the left and the right crust. If it is a competent hiatus hernia, it's a competent hiatus, the two pleura which are lying like this on either side of the esophagus, okay? They are part of the anti-reflux mechanism also, isn't it? So whenever intra-abdominal pressure is raised, they close the hiatus, isn't it? And when they do this, they are compressing upon the esophagus from outside. So you will see an indentation or compression of the esophageal mucosa happening whenever the hiatus closes. And you can elicit this in a normal patient. You can elicit it. Again, importance of having a patient in awake sedation. When you are looking and trying to assess this area, ask your patient to say, utter the syllables or like, Whenever you do this, you will feel the muscles are contracting, the hiatus is closing. You will see the impinge here somewhere. Okay? This is known as a diaphragmatic impinge. This indicates what? The level of the hiatus. Wherever the impinge is happening, that means that is the level of the crust. Crust means hiatus. So, the distance between, so now you note down that. Okay, take the scope tip to that level where you see the indentation, diaphragmatic impingement, and note down the markings at the level of incisors. It could be 40. Then come back, bring and keep the scope tip at the level of anatomical G junction. Again, note down the findings. It could be 38, 39. So difference of 2 centimeter or less. This is normal. Now let me put it in one sentence. Distance between the anatomical G junction and the diaphragmatic impinge should be 2 centimeters or less. This is normal. No hiatus. But now, if this G junction herniates upwards, as we just saw in this picture, isn't it? The G junction is present somewhere here, and at inside. But now this is herniated upwards. Now what will happen to this distance? Now if you measure the distance between the anatomical G junction and the level of diaphragmatic impinge, it will move. Because hiatus is fixed. Isn't it? So the distance increases. This is how you diagnose hiatus hernia on endoscopy. This is how you diagnose. You just have to measure this distance. See where the anatomical junction is. See the impression of the diaphragmatic impinge. Initially, you will have to ask the patient to listen. Later on, you can make out that this is the level of my diaphragmatic impinge. It comes. Just measure that distance. If it is more than 2 centimeters, it is diaphragmatic height. You see here. Now this distance is more than 2 centimeters. From the diaphragmatic impinge, you see that there? And the upper end of the gastric folds. So this is how you diagnose hiatus hernia. So you diagnose it from the esophagus. We haven't yet crossed the G junction and entered into the stomach. So we are still in the esophagus. So you have diagnosed it. But again, you have to grade it. Isn't it? We are supposed to grade it. Hill's grading for sliding hiatus hernia. This is done on J maneuver. This is done on J maneuver. So that means the diagnosis is done from esophagus. The grading is done from the stomach side. So first you diagnose it, then you go ahead, come back, J maneuver, and see how we diagnose it. You see, this is the cardia and this is the scope which is entering into the stomach. A competent cardia is supposed to be snugly wrapped around this scope. Snugly wrapped around this. You see this? But if you have a hiatus hernia, then this will appear laxed. And depending upon that laxity, you grade it as 1, 2, 3, 4. You see here, if it is mildly relaxed, you will see some gap between the cardia and the scope. You see this small gap?
Yes, sir.
And if this is further dilated like this now, what will you see on J maneuver? What will you start seeing here?
Yes, sir.
Yes, you will start seeing the lower part of the esophagus mucosa also. You see, now it is further dilated, and what you see here, what is this? You are seeing the Z line on J maneuver. Appreciate this. Isn't it? That means it is opened up like this, so that you can see the Z line also. If it is further opened up, you can even see up to the lumen of the middle 1/3 of the esophagus. You see, now you are seeing all the way up. You see that? So, this is how you grade 1, 2, 3, 4. Okay? This is the Hill's grading for sliding. What about paraesophageal hernia? In this, the G junction is at its normal position. So when you do endoscopy, you will not find a hiatus hernia. G junction is not migrated. Stomach has herniated alongside this. So now understand this picture endoscopically. This is the cardia snugly wrapped around the esophagus. But when you do a J maneuver, you see an additional lumen here. You're not supposed to see this lumen here, isn't it? What is this lumen? This part. You are seeing this part, isn't it? This part. Because this entire stomach has now herniated above and is lying above. You are seeing this additional opening here instead of under. The stomach is beyond this. It has herniated to the height. This is how a paraesophageal hernia. Obviously, you can keep a differential diagnosis of a fundal diverticula also. Large fundal diverticula will also look like this, isn't it? So always keep differential diagnosis in your mind, but both will look the same. And in a combined variety, you will have everything which is opened up. You see that? See the laxity around this. This is the scope, and this is the entire thing opened up. And the rest of the stomach is also lying in the chest. From the esophageal side also you see this is the entire stomach. This is not the G junction, there is a G junction. This is all stomach which is lying. Okay? So this is how you diagnose hiatus hernia. Next common condition is reflux esophagitis. Reflux esophagitis is not a clinical diagnosis. It is an endoscopic finding. It is an endoscopic finding of the clinical diagnosis of gastroesophageal reflux disease.